Hello, everybody, and welcome to the first January 2022 Population Health Collaborative meeting. My name is Bianca Kurtzen, and I am with Constellation Consulting, and we are the convener of the collaborative. The Population Health Collaborative is funded by the New Mexico Department of Health, Heart Disease, and Stroke Prevention Program. Today's presentation and panel discussion will cover utilizing the electronic health record to identify patients with undiagnosed or uncontrolled high blood pressure. Please note that today's meeting is being recorded. Attendees' cameras and microphones are activated. However, we do ask that you keep your microphones muted. Following the panel's discussion, we will have time for Q&A. I ask that you please write your questions in the chat, or you can ask them live once we are done with the panel discussion. Also, if you would like to make sure that you are added to our collaborative email list, you can please send it in your email in the chat or email me directly at bianca@constellationnm.com. So now we are pleased to have Dr. David Larson. Dr. Larson is a physician informationist from Christus Health in Tyler, Texas. He received his Bachelor's of Arts in German Literature from BYU in Provo, Utah. He then attended medical school at Midwestern University in Glendale, Arizona. Dr. Larson completed his family medicine residency in Tyler, Texas, with the University of Texas, where he served as chief resident. He also received his MBA in healthcare management from the University of Texas at Tyler and a master's degree in clinical informatics from the University of Texas Health Science Center at Houston. Dr. Larson is a board certified physician in both family medicine and clinical informatics and cares deeply about utilizing healthcare data in more efficient, user-friendly, and meaningful ways. Please help me welcome Dr. Larson. Thank you.
Thank you very much for that, Bianca. It's a pleasure to be here today this afternoon. Just a quick sound check. You can still hear me, correct? Okay.
Correct.
All right. Well, let's dive right in. I was asked to talk about using the EHR to find patients who have undiagnosed high blood pressure, or those who are suboptimally controlled, or perhaps those who just need a little more tender loving care through the EHR, and different ways we can outreach them. Next slide, please. A little background on the organization I work at. I work at Christus Health. We're a growing organization. We're multi-state. We're actually pretty large in South America as well. This is the most recent map I could find. I'm based out of Tyler, Texas, but we have clinics all over the place, including our wonderful counterparts in Santa Fe up there. Currently, I'm traveling myself. I'm in Shreveport over here on this map, doing an optimization session today. But we have several centers, more than 600. We have 15,000 physicians we work with, 50,000 employees, most of whom utilize Christus Health for their own healthcare. And so we have a lot of data to work with. Next slide, please. I will say that our EHR that we use is Epic. And so the examples that I will be using are from Epic. We're still working on converting everyone onto Epic right now. So we still have a few systems that are on Cerner or Meditech, but we are getting there. We're focusing on getting a one platform system. It's a process. And so even though the examples today are from Epic, just know that you can apply those principles generally. Next slide. So on to hypertension. Hypertension, if you're unaware, it's commonly called the silent killer for good reason, mostly because patients can't tell when they have hypertension. Other complaints like broken bones or diabetes, a lot of times there are clinical manifestations that patients can feel, but almost always patients have no idea their blood pressure is high. There are a few patients who can tell, mostly in the form of headaches, but by and large, asymptomatic. And the other dangerous thing is this affects every single organ. If it takes blood, it can be affected by hypertension. And the CDC estimates that hypertension costs them $130 to $190 billion each year. It's a very costly disease. And so because of this, there are many large incentives for payers and health plans to control this disease much better. So a little outline for everyone. Next slide. I thought it would be useful to kind of go broad and then zoom in as we go. for different tools that we utilize in Chris's Health to identify these patients. I'm going to start with dashboards. We're going to go into reports. I'm going to talk briefly about some clinical decision support tools that we use, and then outreach strategies, of course. All right, so let's start with dashboards on the next slide. This is a classic picture of a dashboard that we've probably all seen. This one's pretty good. It shows you different colors for if you're passing, yellow if you're close, red if you're failing. You can see the different metrics that we're tracking here. There's even different quarters at the top. It's an okay dashboard. It's not ideal, but you'll see these all over the place. And on the next slide, I want to show you why are we focusing so much on dashboards. Dashboards, there are several studies to show this, but dashboards really do enable better decision making. And they do this for several reasons. If you're on multiple EHRs or getting your data from multiple sources, dashboards are the best way to summarize and display those data from multiple sources. If it's done correctly, you can see lots of information at a glance. You can easily see trends and gaps. You can make quick decisions. And if it's a really good dashboard, it's also interactive. Not all of them are, but they can be pretty good. And not just why dashboards, but I want to show you who needs to use these dashboards. This is an example of how we're doing it in our organization. There's an executive level at the top, and there's different dashboards for those people. We have a population health outreach team, for example, that uses dashboards for everything. They decided the best way was to divide those different dashboard subtypes by payer. I know a lot of places divide it by geography or by clinic or by hospital system or by region. We found that payer was a little easier just because we can have specialists in each of those areas that know the different payer types. It works pretty well. Going down a little level lower, we have a quality team. They use dashboards for lots of things too, mainly our value-based metrics. Our different payers who incentivize us to take good care of our patients, high quality metrics that are defined. Our quality team monitors these closely, not only to see how well we are doing, but also to adjust and stratify those value-based metrics for the providers. We usually renew them or readjust what those metrics are each year. And then lastly, and probably most importantly, is the providers. Physicians and APCs need to have access to these dashboards. If it's in a place that's hard for them to find, it's not going to be very useful to them. So we actually put these dashboards right on their homepage. It's the first thing they see when they log in. And I'll talk more about that in a minute. But on the next slide, you can see same dashboard. This is what our population health team sees. But let me show you how you can make these interactive and actually pretty helpful. So on the next slide, if you were to choose one of these metrics, I'm just going to choose blood pressure since that's today's topic. An important part of a dashboard is defining what the metrics are. And we really like hover to discover. Epic does too. And if you hover over that measure, you can see precisely what it's measuring, the patient types, their ages. You can tell that it's kind of hard to see the trend unless you're really good at numbers. And so you actually can graph this. I think graphical interfaces are much better. So that hyperlink at the bottom will display a graph. And then lastly, that bottom hyperlink, the diabetes care blood pressure control, if you click on that and then go to the next slide, we'll just pretend we clicked on it. It will bring up a list of all of the different clinics and how each clinic is doing. You can even go down further. Like if you want to see the Athens family practice that we have, and you want to see how each provider is doing, you could click on Athens, which takes us to the next slide. And I had to black out some of the names and falsify some of the data here, but you could see each provider and how they are doing. If you have one straggler or one person who's really struggling to control hypertension, some interventions could be made there. But like I said earlier, our population health team really likes to focus on payer type. And so if you click on one of the providers' names, which is our next slide, you can see how population health works. They can go down through each of our value-based payers here, like TISD or Christus Medicare Advantage patients. And then from there, they can get a chart with each patient's name, demographic, phone number, et cetera. And that's the next slide. So having these dashboards that give you an at-a-glance view is important, but also being able to use those a little further and be more specific in these so that way you can actually outreach these patients and make changes. Very important. Let's go to the next slide. And this is, we're going to do an example from a provider standpoint. Providers, physicians, APCs, nurse practitioners, PAs, they're some of the most competitive people I know. The odds of doing well on your MCAT for med school are really low, and then the odds of getting accepted to med school are even lower. Once you're in med school, it's not over. The odds of doing well on your steps are low, and then matching into residency. I mean, it is extremely competitive. And for someone to finish that, you know that they are going to be a competitive person. And putting these dashboards with color metrics where providers can see them, in my experience, providers like to be in the green. They do not like red. It makes them feel bad. It makes them feel like they're doing less than their peers. And we use these a lot. And if you link a financial incentive to these dashboards, that plus their competitiveness, you're going to get physician involvement, which is very good. Now, our providers see a dashboard just like this, but when they hover over each one of these categories and then click to see their patient list, they don't get quite the interaction that an executive would or a population health team member would. They instead get a report, like on the next slide, of their own patients. And they can click on those charts, they can do interventions if they know the patients well, they can send them messages, prescribe things, schedule appointments, etc. I'll talk more about outreach at the end of this, but using these from an executive level, a team level, and a provider level are critical for making these decisions and identifying these patients. So that's dashboards in a nutshell. Let's jump into reports. If you've never had to deal with a report before, it can be very frustrating. Let me tell you the typical life cycle of a report. Usually, if you're using a single data warehouse, meaning like if we're all on one electronic health record, it is much easier to pull data than it would be if you have a conglomeration of data. Like if we have, we're using 4 different EMRs to try to get our data together, it's going to be very difficult. Usually, someone in leadership, they usually have the word chief in their title. Sometimes the word financial is also somewhere in their title. They recognize something in the healthcare system that they need changed, but they don't quite know how it needs to be adjusted or talked about. So almost always there's a consultation with physician leadership, like a chief medical officer, or someone who understands the clinical aspect of what's going on. Together, they have to drill down what type of data is important to not only identify the problem, but track the improvement of the problem. But neither of them know how to do that. They come up with their wish list, and they have to give that to an analyst who then has to usually input multiple SQL queries into their database. They get that data back. They have to standardize it with an XML schema. They then have to convert it using an object relational database so that way each component is correctly identified, and then turn that into a report. And that takes several days. And often when you get the report back, if you do this a lot, you know that it's almost never correct. There's usually extra things that you realize, oh, I should have put that in there, or the wrong component was pulled. It's very frustrating to use reports, but they're extremely helpful. So it's this catch-22. So if you're ever dealing with reports, there are 3 questions I always want you to think about, and these are on the next slide. Question number 1, which data elements from the data bank that we're pulling data from, which of these elements are actually reportable? I know Epic gets a lot of grief because it's very click heavy, and there are 10 different ways to do the same thing. But the beauty of Epic is every single element has a smart data element attached to it, and almost everything is reportable. It is wonderful from a reporting standpoint. From a clinician standpoint, it can be very frustrating, but from a reporting standpoint, it is excellent. I also want you to ask yourself, is the data we're looking for discrete or non-discrete? An example of this would be if you're looking at physical exam components, and some of your clinicians like to free text an exam, and others like to click buttons that are captured as discrete data. And you run a report looking at physical exam findings, are you missing half of your data because the non-discrete data is not captured? That's a very important question. And then lastly, do integrated smart devices and other things, not just smart devices, but are there other factors that can influence these reports? An example of this would be glucose readings. If patients have an online patient portal and they have a glucometer at home that interfaces with that, are those data pulled into that report? Or do you only track readings that are done in the clinic at your own lab? You know, blood pressure devices that integrate. Do you count home readings, or could those be falsified? You know, do you only track blood pressure readings done in the clinic? What I'm getting at is anytime you get a report, I want you to always question the report. Reports are great, but there is no such thing as a perfect report. So on the next slide, let me show you an example of a report that may be useful for something like this. Epic has a great tool called Reporting Workbench, which is quite user-friendly. And this is a simple example of a basic report that you could run. You'll see the logic at the very bottom is we're looking at data point number 1 and data points number 2 or 3, and not data point number 4. So I want all of my patients on my panel who are still alive, who have either a systolic greater than 40 or a diastolic greater than 90, who do not have a diagnosis of hypertension. And we do these grouper diagnoses, so any subtype of hypertension would be counted in this. And doing something like this is a whole lot easier than writing SQL. So, you know, if you click on the next slide, you might get a report that looks similar to the ones we've looked at before. We also have pre-made reports for our providers. They can just click on what they need and these pre-made reports come out. It saves you a lot of hassle dealing with SQL. If you've never seen SQL, I gave you an example on the next slide. You can just see how ridiculous it is to write SQL code. Granted, this example is not a healthcare code, but nonetheless, it's just as complex. And just missing one comma or one semicolon ruins your entire command. It is very frustrating. I do this in our organization. It's great fun. And when it messes up and you have to find someone to help you, it just takes a long time. So please be patient with your analysts. They have a very difficult job. But SQL reports are probably the most robust reports you can get, which is why they're so usable. However, on the next slide, I want you to show you something new that many third-party companies, and Epic is also doing this, they're making user-friendly interfaces for SQL. So you might get a dashboard like this where you can choose different components that you want. Like go to the next slide and I'll show you, you can click on different diagnoses, the diagnoses box, and you could type in hypertension in this box that comes up. And each one of these boxes that you click, in the background, it's writing the SQL code for you. It's truly impressive. We're seeing this more and more. There's a lot of companies that contact us and say, hey, if you don't like doing SQL code, you know, we'd be happy to show our interface that makes it a lot easier, et cetera. And this is becoming very, very popular. So by writing something here, just by clicking on these things, go to the next slide, you can generate a very robust SQL report. You can see this is the exact same type of report we were doing before. It's my patients who have a blood pressure greater than X, who do not have do not have hypertension. It displays all of their names, their charts. You can see a lot of detail about them, and you can contact all of them. So SQL reports are the gold standard, but they are extremely complex, very difficult, and it's hard to find someone who knows all of those, which is why our organization really stresses physician informaticists. It's nice to have someone who's clinical, who understands the clinical side, who also understands the data side, and they can talk to each other. It's a bonus if you have someone who understands finance and business decision makings, having that trifecta, really useful people. But if you're ever going to be doing a project where you're going to rely heavily on reports, I'd highly recommend that you get physician involvement, someone who knows the problem and is also pretty in tune with the electronic health record. And with that, let's go to the next slide with clinical decision support tools. You can run all the reports you want in the world. Sometimes it just takes a clinician to decide if this is really truly hypertension or not. To do this, we try to remind our clinicians, you know, for patients who have high blood pressure readings, but it's not their chief complaint, or they don't have that diagnosis, or people who do have high blood pressure that's not adequately controlled. We try to remind them as best we can to get that under control. And we do this through clinical decision support tools, or CDS tools. And it's very important that you follow the 5 rights of CDS tools. This is common in the informatics world. You want to give the right information to the right person at the right format, using the right channel, and at the right time. Like I mentioned earlier, CRISIS is a growing organization, and a lot of times the new organizations that we partner with, we find that they are really struggling with certain metrics. Take hypertension, for example. We speak with the chief medical officer or quality, and they say, we've done everything we can think of. We have hard stop pop-ups that show up, and our clinicians are still ignoring them. And we take a look and we realize they're letting these pop-ups show immediately upon opening the chart. And if you don't know this patient, or they're in the emergency room and they're here for a cut, and you don't even know what medications they're on, and this pop-up shows up that says, look for their blood pressure, of course you're going to close it and ignore it. That was not the right channel, and it was not the right time to display that. And so pop-ups like this one on the next slide are very helpful if they're done correctly. So here's an example of we call it a BPA, best practice advisory, that we use in our organization, reminding our providers that this person has a comorbid condition, and according to guidelines, their blood pressure goal should be lower than what it currently is. We had a long talk about where should we make this fire, when should it appear, and we found it is most easily acknowledged and followed when it's done in the plan section. This is after the provider has already reviewed the chart, they've already seen the vital signs, they're in the room with the patient, and they're in the same section of the chart as when they start prescribing medicines. This is when this shows up, and they say, oh, right, I forgot we were talking about 6 other things, but your blood pressure is high, let's talk about that. Sometimes the right channel that we talked about earlier is simply just making the blood pressure that's abnormal red or bold, like you see on the right-hand side here. Sometimes that's the correct avenue. But following these 5 rights in any type of clinical decision support tool that you're going to integrate is crucial to making it actually usable and having people comply with it. Next slide, another tool we use. You can have this fire all day long, but if patients aren't taking their medicines, it's not going to matter. So we have a medication adherence tool that we use. This is an interface between our EHR and SureScripts. And you can see as a provider if the patient has actually picked up their amlodipine, if they're being compliant with getting their medications. We can't know if they take them, of course, but we can see if they got them from the pharmacy. It's a great tool. Reports oftentimes will overlook this and simply won't tell you that. On the next slide, we try to have a lot of embedded tools in the EHR as well. For example, that last bullet point, this is a slide from one of our last quarterly quality updates, just a reminder about what to do for hypertensive patients. And for example, if you need to give a patient education on controlling their blood pressure, we have preset pamphlets that are in the system that you can type a phrase in and it prints it out for you. You can give that to the patient. I'll show some of these other ones. There's my chart flow sheets. I'll show this in the outreach section. There's nurse blood pressure follow-ups. I'll show you that too. But educating those providers, remember how I told you how competitive providers are? Educating these providers and reminding them about this, and using dashboards on the next slide again. Dashboards just like this do a lot more than most people think. Just changing where that dashboard is displayed has made such a difference with our providers. It's truly impressive. All right, the last section, and my favorite and the most important section, is outreach. There are dozens and dozens of ways to perform outreach. There was no way I could list them all here. I thought about how many I could do and what we could talk about. And honestly, this entire lecture could be on outreach. I suspect many of the questions and some of the panel discussion we'll have afterwards will be on outreach, but let me show you a few principles of outreach with some examples. Go back one slide if you don't mind. This is an example of virtual outreach. In the past few years, we've had to very much adapt to virtual medicine. And I think in the past, this was something that was very foreign to a lot of people. But even our elderly population has really embraced virtual outreach. I did a video visit last week with a 94-year-old. It was wonderful. And so these are new technologies that are being standardized. One example here is, I'm sure we've all encountered this if you're a practicing clinician, where you have a patient who has a new diagnosis of hypertension. You want them to take a medicine and you want them to come back soon to recheck their blood pressure. But blood pressure is tricky. It takes 3 or 4 tries a lot of times to get it correct. You don't want to overtreat, you don't want to undertreat. And so often patients have to come back 3 or 4 times to the clinic. That's expensive, that's time consuming, and it's not very convenient. So one thing that we use are these flow sheets. We can order a blood pressure flow sheet that goes to our patient's portal account. It's called a MyChart account. And if they have a blood pressure cuff at home, they can take their own home readings and they can punch them in and they'll come right back to the provider. We do let you stratify how many you're going to see. If I don't want to see any of them until the patient has entered 7 readings, you can choose that here. You can have preset text that goes to the patient if the blood pressure reading is too high. You can say, I want you to wait for 30 minutes and then check it again. If you're still having symptoms, call our office. Or if it's too low, I want you to skip your next dose. You can have a lot of this automated, and you can make decisions remotely without the patient having to come in. And so oftentimes I'll get these back, it's still uncontrolled, they're not responding well to low sartan, for example. And so we'll start another antihypertensive remotely without any visit. And once their readings are under control for these home readings, then I bring them back into the clinic. So they only have to pay that 1 extra copay. They can see how well their blood pressure is doing. We've already talked about interactions over our patient portal, and they're controlled. It's a much better experience for the patient, and it's much more convenient for the providers. Next slide. Now, this is something that is new, and this is bulk messaging. Providers use this, our population health outreach team uses this. If you run a report in Epic, you are able to select those patients, as I mentioned earlier, and open their charts and contact them if you want. It's pretty time consuming to contact each patient. Sometimes you need to do that, but oftentimes an easier strategy is to run the report, get all of your patients who are uncontrolled or not meeting some certain metric. And then on the next slide, you can see that you can send them all a customized personal message. This is a very clever tool that Epic has done. You can see the first line of the message is "Dear @M @L name." And what this does is, again, those smart data elements, this will write "Dear Mr. Larson" or "Dear Mrs. Smith," and it will personalize the letter for them. And they'll just say, we're trying to take care of you behind the scenes. We noticed your blood pressure was not adequately controlled. We'd love for you to come back in for a nurse visit to make sure that you are healthy. This will be done at no cost to you, and you can schedule this online. If it's other metrics you're looking to do, like diabetes, not only can you bulk message, but you can bulk order. So with this same message, I could order a flow sheet for blood pressure control to these patients. It's fantastic. And then the patients you don't hear back from that don't respond, those you can individually contact either by phone, email, snail mail, whatever you need to, and take care of them that way. It is a wonderful tool. And this one mentions the nurse blood pressure visit. Let me talk about that for a minute on the next slide. One thing that we found was that using nurse blood pressure visits improved our metrics by several tens of percentages. And what we've decided is patients can come back at no cost to them to any of our primary care clinics just to have their blood pressure rechecked. If they don't have their own machine, or they want someone who knows what they're doing to check their blood pressure. And this takes 5 minutes, 15 if they're uncontrolled, and they just sit for a while and have their blood pressure truly go down. And it's remarkable. Our nurses love doing it. It's a very quick and easy thing for them. It's not very disruptive to their day. And what we do in our system, at least, these readings that are done in clinic actually count towards the provider metrics. The home blood pressure readings that patients can enter on flow sheets, we generally don't track those, we don't count those. There is one exception to that, but usually those, it's a possibility they could falsify that data, and we just don't want to risk those home readings being counted towards these value-based metrics. So this is a great program. I highly recommend that you think about using this. It's been game-changing for our hypertensive patients. And then next slide, this is, we have dozens of pilots going on with hypertension. I just decided to include one of them here. But one thing that we're doing is patients who have uncontrolled hypertension who are on one of our value-based payer plans, we have a grant to give them all blood pressure monitors. Now, not just any monitor, these have to be electronic, has to have a display on the screen, it has to interface directly with their smartphone and therefore directly with their account. And that way these patients can take their blood pressure reading, simply click a button, see where they're at, and then get a message back on their phone with instructions on what to do next. Most of the time this is automated, but this has been so wonderful for our patients, especially the elderly patients who may not know how to work technology or may not have the means to come in every month for a visit, or they live really far away. It's just been such a great thing to do. So there are dozens and dozens of possibilities with outreach here. But just in summary, on the next slide, I just want you to think about ways that you can use these dashboards, drill down from those dashboards to get reports, use clinical decision support tools, and use all three of those to figure out which outreach strategies will be best for you. The possibilities are truly endless with this. I could talk about this for another hour, but I know we have a panel that really wants to discuss this with us too. And so this is actually the end of my presentation. I kept it a little short. We're right at 33 minutes. They asked for 35. So I left a slide there for questions, but Bianca, I'm going to hand that to you. I'm not sure if you want to do questions now or later.
Yeah, so if it's okay with you, could you hang out for another few minutes after our panel, and then we'll kind of have a collective question for everybody. So thank you. That was great. I appreciate it, Dr. Larson. Thank you. So now I'm pleased to welcome our panel. So I will introduce them. Edie Taylor is an improvement advisor at Co-Imagine Health. Ms. Taylor has over 30 years experience in healthcare and is also a registered medical assistant. Alberta Davis is an associate improvement advisor at Co-Imagine Health. Ms. Davis has been with Co-Imagine for the last 9 years and has worked in many aspects of quality improvement for hospitals, medical offices, and community organizations to help improve the quality and health equity for all Medicare beneficiaries throughout the state of New Mexico. We also have Mr. Cecil Pollard. He's an assistant director for the Office of Health Services Research at West Virginia University. Mr. Pollard has a long career working in medical data for research and quality improvement with a primary focus on chronic diseases and standards of care, and has served as an expert panel for the CDC related to chronic disease patient registries. And lastly, we have Ms. Terry Stewart, who's the Chief Administrative Officer at Synchronous. Ms. Stewart has over 30 years of experience working in statewide collaborative organizations in New Mexico. So first, I want to start with a question for Ms. Stewart. If you could just tell us a little bit about what Synchronous is doing to support providers in the state of New Mexico when it comes to identifying these types of high-risk patients in New Mexico through your HIE and through your company, your organization.
Thank you, Bianca, and thank you, Dr. Larson, for your presentation. And Synchronous is the state of New Mexico's designated health information exchange. So like an Epic electronic health record, Synchronous has dashboards and a portal that allow healthcare facilities and providers to look at individual patients' medical record, but not coming from one healthcare system or one electronic health record. We create a longitudinal clinical record that has data from the majority of hospitals in our state, federally qualified health centers. We receive all of the Medicaid claims in the state, as well as other payers and other ambulatory clinics. So we have a repository with a robust data set from multiple healthcare facilities, so a provider can see beyond what happens only in their four walls or within their organization. So that is, in a summary, the tools and what we have to offer.
Thank you, Terry. I want to go to Edie. I did, just because of your experience as a practice manager, being in that side of things. Can you just tell us a little bit about your experience using an EHR to identify those patients, outreach, and then in your current capacity, kind of how's it all came together?
Thank you. Thank you, Dr. Larson. What you brought to the table was very interesting and exciting for the work that we do. Coming from an office manager space and coming from a world that transitioned from paper records into EHRs, I've really seen that develop. And initially, it was very hard to get data out of an EHR. And we've seen EHR vendors become kind of the teachers in how we do that. It's still not perfect. Pulling data sometimes is, even harder than pulling teeth. But I think systems like you've shown and those dashboards and things like that help make changes within systems that providers didn't get to see when they were on paper records. They'd have to wait for a report from CMS or, their system. And often it was so old information that they couldn't enact change. So it's things like dashboards that really help to push that change quicker. They can, in real time, see patients who are at risk for diabetes, heart disease, those types of things, and make changes ahead of time. So really seeing that transition from the paper record system where we didn't really know where a patient stood to have a real-time dashboard is just phenomenal to see that technology.
Yes, I definitely agree. I'm going to go to Cecil. So you have a little bit of a different background, right, Mr. Pollard? So you're more in the academic and research area. So tell us a little bit about what you've experienced or what your background is and what you can share with the group.
Well, first of all, I want to say that I really appreciated that presentation. And that's about the strongest argument I've seen for why we should have one EHR across all the systems. I mean, I think part of what we try to do is to bring a lot of those elements to our community providers that don't have that capability. They don't have the staffing or the technical support to actually use their data that well. So in terms of my history, it goes back a long way. We used to do abstract data from paper records and put them into a database to do data collection that way and to create registries. And we now work with a variety of EHRs depending on who the client is, and help them move forward with how to use that data for managing not just hypertension and heart disease, but all kinds of chronic diseases primarily. And I think one of the things that we learned very early on was that it doesn't really matter how good your EHR is until you get the data correct. And I think a lot of that is, I've gone through an Epic implementation at our health science center, and that is an amazing process and very difficult to make that transition. And then you hope and pray that they never change EHRs, that they just that they keep that one. But it was really great to see that. You showed me things in Epic that I didn't know were there because I don't work with it on a daily basis, but it's really got a lot of the components that we need for our population health collaborative. So we hope to keep moving those skills and that information forward. I don't know I hope I answered your question.
That was perfect. Thank you, Cecil.
Okay.
I actually have a quick question just for Dr. Larson. I'm not familiar. I've never worked in Epic. I've worked with several different EMRs, but are a lot of those standard? Are these add-ons that a practice would have to add on in order to be able to see those dashboards to kind of drill down to the provider? Are they extra costs on a practice? Are they kind of standard based on what your experience?
Yeah, these are standard. These are Epic native functions. We try to stay as close as we can to Epic native. When we first went live in 2010, we wanted all these extras and we built out our own things, and they were really nice and customized to the Northeast Texas region. But as we expanded, we found that it was just impossible to keep up with all of those customized aspects of the EHR. And so we did a step back and we said we really need to go back as close as we can to Epic Native and have them manage all of our updates and have them make sure everything is accurate. Otherwise, things are going to break every time we have an upgrade, which is every 3 or 4 months. So all the things that I showed today are standard. They don't cost anything extra when using Epic. I can't speak for our other EHRs. I know we have several people on Athena, on Meditech, on Cerner. I don't know about those, but I know with Epic, each one of these components is standard.
I know from my experience, eClinical Works, and they have a really cool HEDIS dashboard, for example, that they're trying to but it's an extra cost. It's per provider. It's always not always beneficial for a practice to have that investment. So I was just curious.
Well, it's not to say that Epic is cheap, because it is not.
So you're paying for it you pay for it at the beginning as opposed to in pieces, right? Or add-ons. Right. Exactly. Okay, so before I go into questions, just Alberta, if you want to just give me a quick background on your experience and how CoImagine is really trying to help our providers here in New Mexico and what we're doing for outreaching for patients.
Sure. So our part is to we're focused right now on creating learning sessions on taking proper blood pressures for systems to help ensure their staff are properly trained. We know that after a while, if someone starts doing something differently, then they will continue to do that differently. And all of a sudden that becomes the norm instead of the other step that, oops, is now not really being incorporated, like both feet on the floor or an empty bladder, or having the patient sit in a waiting room for at least 10 minutes so that they're not flying in from another appointment and then sitting down and having their blood pressure taken. We've also provided educational resources to staff and for patients and staff. And right now we're collaborating with Cheryl Wilkeson of the American Heart Association, and she'll be presenting to the health systems about about what they have as resources and their ability to provide, sorry, I just got a delivery, their ability to provide assistance in the realm of self-measured blood pressure and cardiovascular issues sometime in March. So that's what we have on our plate right now.
Great, thanks, Alberta.
Of course.
So we did have a question come in, so I'm going to maybe pivot to Edie or to Terry. What is the impact of connecting pharmacy records with clinical records? In New Mexico, CVS Pharmacy is now connected to Epic in the Presbyterian MyChart platform. So who wants to take that one?
And I'm happy to tell you what we're doing. I think from a population health perspective, if you can combine pharmacy records, medical records, and even claims records, you're able to get a very robust tool to be able to provide feedback, even on dashboards beyond hypertension. And in the HIE, we have all of the pharmacy claims for Medicaid recipients in our state, which is about 48%, but it means we're also missing 52%. And that's part of what we would like to add to it, but I think it gives more information because that the patient was not only prescribed the drug, but at least they filled it at the pharmacy, and then whether they took it and whether they took it according to the directions, that's a whole other process. But if Press knows in the Epic system that the patient went to CVS and got their prescription filled, that's closer to knowing that they've taken it.
Perfect, thank you, Terry. Cecil, did you want to make a comment? I see your hand's up. I think you're on mute. There you go.
That was a weird thing that happened on my screen rather than my microphone. I actually had a question, but related to that question that came up, we've had problems in the past because we haven't had access to pharmacy data. We will have access in the EHR of medications that have been prescribed, but as you were saying, was it Terry? Yeah, as you were saying, you don't really know if they actually fill the prescription or not. So that would really be helpful in some of our population health efforts to know that, number one, the medication was subscribed or prescribed and maybe reevaluated at some point, and that there was actually the prescription was filled. But we don't have that. Often we don't have that now. It'll be interesting to see how quickly that goes around to the other EHRs. Like I said, it would be great if we all just had one EHR to deal with, because they're all very, very different.
Yes, I agree. And I
The
think
question if it would be
Go ahead.
okay or not.
Dr. Larson, so I think you mentioned a little bit about that, not knowing if the patient picked up the we knowing that they might have filled it, but if they took it. So does that go back to just outreach and having those outreach programs and having those conversations with the patients to making sure that they're, we're circling back and making sure that they are taking it adequately or effectively?
Yeah, that's really the only way right now. Big Brother can only go so far. But other things that pharmacies do, we notice when CVS, integrated with Epic, it also helps with other components, not just medications, but they administer a lot of immunizations. We were able to track COVID immunizations a lot easier, or Tdaps, or PCVs. So immunizations was a huge deal when they merged, and we were also able to get more data on. What we did is we made kind of our own dashboard of medication adherence, and when medications were not adhered to, we would try to reach out and find out why. And so this created another component in our dashboards about cost. And in population health, I know that's very important. Sometimes medications are just too cost prohibitive and patients can't use them or get them. And so now with the newest version of Epic, you can actually see which health plans cover which medicines, and you can see the cost estimation, which is very helpful to patients as well. But as far as if they've actually taken the medicine at home, there's no way I know of right now to know that without actually reaching out.
So Cecil brought up another good point about what's the percentage of patients who are signed up and using my chart, right? And so is it, are they using it effectively, or do they, are there barriers as far as technology and different things? I don't know if we have an answer for that, if we know how many people are using my chart, but I think that's a great point to make.
Yeah, I have two screens. I'm going to mute myself and log on, and I'll give you an answer in just a second.
Terry, did you want to make a comment while we wait for Dr. Larson to pull that up?
Right, and I just want to comment on Cecil's comment of everybody having the same electronic health record. Well, that won't happen, and that's the function that the Health Information Exchange or RIC, or there are very many names, in every state has a Health Information Exchange, and that provides the opportunity to take the disparate information from the various healthcare facilities and provide a platform and dashboards to look at data across all of them. And that's really what we're creating here in New Mexico.
Thank you, Terry. Dr. Larson, were you able to pull it up, or are we still waiting?
Yeah, there's quite a few dashboards. I'm trying to find the right one.
No problem. So Terry, if you could talk a little bit, I know you have that population health dashboard through Synchronous, correct? Your population health dashboard that you all use as well. Could you speak to that a little bit?
Well, I mean, it's very similar to what Epic uses. We have partnered with a company called HBI Analytics. It is a spin-off of technology created at Stanford, and it allows for an individual practice to have, or a hospital or a payer group to have patients attributed to them and their work, and they're able to look at quality measures, HEDIS measures, gaps in care, and be able to see at a population level what percentage of their patients are compliant, but then they can drill down to the actual individual and see that it would be Terry Stewart who was not compliant. It also, if they logged on to the system before a patient visited, it would identify, based upon the information we have in our clinical data repository, if there were gaps in care. If I had not yet had my mammogram, if I had not had, different healthcare procedures done according to my sex and my age, that would be identified and flagged. So that is the population health tool we have now that would allow you to look at again, your overall population as well as the individuals. And we are working with a local company to develop a more extensive community insight tool to do some population health, but that won't be ready until next year.
Thanks, Terry. So we did get a question in the chat here. As an independent community pharmacy who is working with the Department of Health on HPS, PP, and diabetes as well, it would be helpful for our site to have access to their medical records as well. We would like to share information to providers about all of our interactions with our patients on these programs, but it would be great to have access to an EHR to create a better health care team approach. So I think that's basically kind of what we're all discussing about.
Right. And independent pharmacists do have access to the HIE if, I mean, there's contracts and all of that, but that's how they have access to that information. And pharmacists within the Department of Health and other agencies in the Department of Health also have access to be able to see that information and share it amongst their programs.
Yeah, so just to back up to Stephanie's question, another question is asking, how do we support community pharmacies to connect to EHR data as well? So what you're saying, Terry, is that's why the EHI exists, to be able to connect these outside partners for one particular patient or population, correct? The HIE, excuse me.
That they could connect to the HIE to view the data that is in the system.
Because aside from that, there's no other way, right? And so we all use our own little silos and EHRs, and we don't communicate.
Well, I wouldn't say there's no other way. I mean, when I was a practice administrator, my staff had access to granted by each hospital in the community. So
portals, yeah, they're portals.
So then they would go into the portal for Loveless, they would do it for Press, they would do it for UNM, and be able to access the data they needed that way. The alternative is you could have one log on to the HIE to see that data. But we're not a complete EHR either. I mean, we take what are key information and from all of the organizations. So we do not have a complete electronic health record, that is in, comes from Christus. I mean, that's a more complete data set.
Dr. Larson, were you able to find that percentage?
Yeah, I was actually about to
question?
type it into the chat. We're hovering right around 60% MyChart activation right now with our patients. And that last question with the pharmacy, man, that's a tough one. Especially if you're in a community that has multiple healthcare organizations and they're all using a different EHR, that is a tough one to answer. So I know there are read-only versions of EHRs that we can grant access to our community providers and pharmacies if we need to, but still it's the gamble that they participate in that healthcare organization, and there's really no good answer. It'd be nice, like Cecil said, if we're all on one EHR, it'd be wonderful.
Edie and Alberta, any other closing comments or thoughts as we wrap up the last few minutes?
Dr. Larson, I have a question for you. You had mentioned your pilot program that you're working on, and one of the things that we're currently working on with some of our systems is to help them get self-monitored blood pressure programs started. I know we're short on time, but just hearing about that, kind of sparked the interest for us.
Any particulars you want to know about it?
Where did you get started with that?
Oh, it was actually an initiative by our population health team. I can't tell you where they got the grant money from. I have no idea. I can follow up and get back to you on that one, but
that's okay. We can actually work with our partners through American Heart to help get them grants as well. So that's one of the things we're working on. But just hearing that there is a pilot program going on somewhere in our country that we can link to, so we may definitely reach back out to you just to hear more and kind of more on that.
Happy to help.
Great, thank you.
And I can connect everybody via email after this, so you all have your contacts.
Thank you.
Alberta, any last closing thoughts?
No, I just really appreciate the forum to be able to network and come up with ideas, and to hear your presentation, Dr. Larson. I really appreciate it. I had the same question that Edie did, like how, where can we do that here? Let's do that, so thank you.
Great. Cecil, any other closing thoughts?
Well, I just want to say that I really appreciated this opportunity, and I think I'll be following up with Terry. I'm more interested in their health information exchange. I knew a little bit about it, that I had looked into it years ago, but I wanted to go back and revisit that to see how much you're covering the population, that kind of thing. But this has been informative, and I really appreciate the opportunity to tell a short story or two.
Well, thank you. We appreciate everybody's perspective and expertise. Thank you, Dr. Larson. I know Terry put Synchronous's email in our website in the chat, so if anybody's interested in learning more about our state HIE. But thank you, everybody. If there's anything else, I will give everybody back their time. If you can please take some time to do the poll that just popped up on your screen, we really appreciate it. It really helps us with quality and making sure that we're being more effective in improving these presentations. So please, if you can take the time to fill that out. And for our panel and Dr. Larson, thank you so much. We really appreciate the time.